Welcome to the third Individualized Talk, and today it's going to be amazing because I am with the most famous guy around the world about full art. Everyone knows him everywhere, so it's a guy from the world, and he's well known everywhere. So I am with the team, also Katerina.
Not the full team, though.
Not the full team, it's missing one guy that I just called him, and I told him he should be here, but anyhow, we couldn't pay the pena. But it is great to have this, and today we are going to focus not in particular in cases or whatever, but we are going to be focused on teaching. Okay, Bernardo, it's probably the man of the moment. Teaching. Bernardo and Caterina, of course, they are a very strong team. I know them because I already saw them working together, and they are the perfect team. They really match on this. So, Bernardo, can you tell us about the courses that you have? How do you have structured your courses?
So, thanks for the invitation. Actually, we are recording this in our training center. And how did this start? So this started in 2021 because, to be honest, I was kind of fed up with the way that I was seeing full art being approached, especially in academic context. I am from the time, and maybe you are from this time as well. That,
I'm a little bit before.
No, but I think on this topic, I think we were on the same page, which was, that kind of old philosophy of removing the teeth of the patient first, and waiting, then placing straight implants, then waiting again, and all that jazz, And that never made sense to me, and and knowing what we know nowadays, that we know since 2003, to be honest, since Paulo Malo wrote the first paper on the Allen 4, that we can do better, and in 2021, after many tries in some online places to try to educate a little bit better, or try to show new approaches, it was not very welcome in other forums, so I decided I will start my own forum. So we created the Full Arts Club, where we could, exemplify every single day. We were posting and posting and posting. It was so crazy that when we were on vacations, I had posts planned,
Oh, really?
So even if I was snowboarding somewhere, I had posts every day, boom, 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 to have some momentum on that. And I think that, if you see one thing one time, 10 times, 100 times, 1,000 times, at some point you have to give up the fight. And, I think that colleagues nowadays, dentists are quite clever population. And this, I think this made sense, to the overall public. And so this was the beginning of the Full Arts Club. It was a Facebook group. Then on the group, colleagues started asking for real course or opportunity to watch over the shoulder. Yeah. And there was so many colleagues that wanted to come and to see applying this palatal approach, transsinus, pterygoids, superiosteal implant. I could not have, I didn't have enough surgeries to accommodate everyone that wanted to come here. So I decided, okay, maybe I have to structure a course to put things together in order to try to explain how we think about the case. And we did the first edition of the Full Arts Club in 2021.
During pandemic?
During COVID. During COVID. And now we are in 2024, and tomorrow we start the edition 21.
Really?
21 editions of the Full Arts Club Master Course, which is this course that we have here in Portugal. Now we are going to move to Lisbon. We are now in Porto, but the next ones will be in Lisbon. Easy flight for foreigners. Yeah. And besides the master course, colleagues asked a lot for real practice on patients. So 2 years ago, we started our live surgery boot camp, which got the fame as being the most difficult course to attend. you know, because
Really?
it is sold out 1 minute after being online.
Okay.
1 minute, truly, Rui. And so we started this one 2 years ago in Rio de Janeiro, which is, in my opinion, the most beautiful city in the world. And yeah, so we offer these two programs now. The master course here, where I do the surgery, or Pedro does the surgery. We do it together. And then for those who want to put, their hands up to work in real patients, we have the Brazil
you can
one.
really do practicing and training on
100%,
patients.
100% on patients.
Okay,
Yeah.
that should be really hard to do, no?
Yeah.
How many surgeries do you have at the same time?
We always have 4 surgeries running at the same
Oh.
time. 4 full arches, not easy.
Yeah, it's not easy surgeries, no?
And the level of difficulty in Brazil, you know the kind of population we are talking about. We offer this like charity project in the city of Valencia, so we have the worst cases in terms of full arch, extreme palatal approaches, no ridge, failed double sinus, failed zygomas. We have those cases that no one wants to touch, but those are the best ones, I think.
Yeah, people are working. I imagine. You know, we talk for years. We know ourselves 7 years and something
Kind of.
like that. And every time we are together, we love to discuss about all these biological things and concepts and everything. And Katerina always trying to pull us apart for us to talk with the others. Otherwise, we stay only together talking. But really, it's amazing because your concept it's to give a patient one surgery only and someone that can get their teeth. And it's not that you do patients with grafts. It's graftless. What you're trying always to do, no? And you have made a mix and a compilation of all tips and tricks to be able to do always
So
these cases.
So the way we structure our philosophy is no grafts, no guides, no delays, and no zygomatic implants. These are the 4 things that we want to try to stay away but still solve the cases always with immediate loading, fixed teeth in the same day. So based on this principle, we had to find solutions that will allow us to do this. So we are talking about the Allen 4, the palatal approach, transsinus implants, a variation of transnasal implants. That is a whole topic.
I know.
Maybe we don't have time to talk here, but there is a distinction between the transnasal and the intranasal approach. And sometimes on the internet you see both kind of mixed. We are also talking about pterygoid implants and your famous custom patient-specific implants that people still insist on calling superosteal. But
even on pterygoids you have small difference because I see some schools are placing pterygoids that passes the lamina. They put about 5 millimeters
inside the muscle,
inside the pterygoid fossa, and which is, in my opinion, probably dangerous because it will touch the muscle. It can give some problems with the lateral pterygoid, of course. So you have one day only on your courses for each of these cases, or how do you have structured your master course?
So the first day we talk about the Allen 4 and the Allen 4 variations, transsinus, transnasal, intranasal, and then the second day we are talking, and the palatal approach also on the first day. Second day is the live surgery day, where the participants see they are either with me at the operating room or they are watching next door live streaming. And then in the third day is the pterygoid day and the superosteal patient-specific implants. So that's how we structure the course. I think is the most logical way to start with the easy approaches, and they always train all of them in these life-size models. These are made custom for us because this is quite difficult. I don't know if you can see there, but this is an extreme palatal approach on the first quadrant and a relatively normal, but it's planned to do a transsinus on the second quadrant. So it's not an easy one. Also, the pterygoid surgery here is quite complicated.
Yeah, because it is asymmetric, yeah.
It's asymmetric, yeah. So our students train all of these techniques, and including the patient-specific implants on the third day as well.
Okay, so and on your boot camp, do they do all these techniques, or they do all these techniques?
In the boot camp in Brazil, we do exactly what we teach here, but in real patients, including custom surgery, as you know.
Yeah,
we also.
That's amazing, because for someone to have this kind of training, they will be prepared for almost everything. I think.
Look, for instance, this is a quite difficult case, right? Here on the model, this was a real case, and this is one of the easiest cases compared to the other ones we have in Brazil. It's even these or worse.
Great.
Yeah. And you know who we have to blame for the difficulty of these cases? Dr. Catarina, because she's the one that filters.
Oh, she's too easy. Let's put her aside.
Yeah.
Very well. So, you are also kind of well known and how shall I say? Well known by being against digital workflows. I know it's not quite like this.
That's not quite true.
I know, but please explain us, because I think people have the wrong idea about it.
Okay, so when we talk about digital, we have to talk about two different things. One thing is to deliver immediate loading by digital workflow. That's one thing, and the other digital thing is to do guided surgery, right?
Okay.
We have to split these things. Sure. So about the digital workflow, what I wouldn't say against, but the reason why we don't use the digital workflow nowadays, it's because it's too slow, you know. Mm-hmm. For us, for our work environment, to do for instance, if you have to put palatal markers, then you have to do a pre-op scan, you have to send it to the lab, then immediately before the surgery you do another scan, then in the end you do another scan, and if you want to be very precise, you have to do another photogrammetry with the position of the implant. All these things, I tell you, this takes 3-4 times more what we do with our analogical workflow.
You need to have lots of time.
You have to have lots of time before.
The case,
and as we say, when we teach these at the course as well, at the second day, our workflow, our analogical workflow, is not assuming a denture conversion. We do a brand new at the day in 2-3 hours. That's the thing. And by doing it this way,
that you need to have someone very well prepared, which is
you need a good lab. You need a good guy. You need a good guy.
You know, that's in some countries that's really a problem.
Yeah.
That's really a problem.
But we have
like UK, for example, they have extreme difficulties on getting someone that can came to the clinic and deliver same-day procedures.
Yeah, with the bite right, we always have the bite right and all that midline. You know, everything. Very well structured, so there is never a mistake. But I know and I recognize that this is not that easy to replicate if you don't have on each country or in each city or in each individual situation. But this is one part of the digital, and that's why I find that it takes a lot of time, you know, to do the full digital workflow. At least today, one day, I think the intraoral scanners in 2-3 years will be, you know, to scan the implants, they will be so precise that we will not need photogrammetry anymore. I think it's doomed to disappear in 2-3 years.
I know people nowadays that use photogrammetry without using the intraoral scanner.
The intraoral scanner. But I think in 2-3 years, one will prevail, right? One will prevail. It will be the iOS. Because with the iOS you get the tissue. With the photogrammetry you just get the implants.
Yeah, right? But what I have saw is that they made photogrammetry and they do a CT scan after, and they match both, and they just go on a line that goes 2 millimeters below the bone. So they can design it from there.
But reading the soft tissue out of a CT scan, it's not accurate.
Yeah, really, but you can accommodate the soft tissue after to this. It's you can discuss. Well,
but the other point about the guided surgery, and this was a very... I made this post 3 years ago at the Full Arch Club, the 9 or the 10 reasons why you should avoid guided surgery.
I remember.
And I was expecting to be, beheaded for that.
Yeah.
But it was the opposite. It was the opposite. Like it is still up to today the post with most likes and most comments. And one of them, actually, someone posted a quote from Carl Misch very recently, like 1 year ago or 2 years ago, and he was saying something that I wouldn't say better, which was, guided surgery is being used nowadays by inexperienced doctors to achieve things they would never achieve by doing freehand. This was not said by me,
the key.
This was by Carl Misch. And this is what we have been preaching since the beginning of the Full Arch Club, which is this. I totally get the usefulness of the guide, but to use the guide, you need to know freehand. Because the guides, they fail, they have misfits, if you drop it, it may break. You have a lot of problems that, or maybe another problem that usually people don't consider, and I think it's my biggest point against the guided surgery, it's that it is based on a false premise. And that false premise is this. The bone that you will find on the real life is the bone that is on the CT scan. And this is a false premise.
Yeah.
This is only true in fully edentulous cases or partial cases where you don't need, extractions or cyst cleaning or, super clean case is easy to do. The guide is super accurate.
Yeah,
but
stacks,
it's a puzzle, right?
Yeah.
But if you have bone reduction, if you have a lot of teeth to extract, if you have cysts, if you maybe you break the buccal wall taking out some canine or whatever, then you cannot
ruin
it
everything.
and then what do you do in your patient? So
Yeah.
you have your flap opened and you say, I'm sorry, but my guide doesn't fit, so I will make another one. That can never happen.
Yeah.
Right. We are doctors. We treat people. That can never happen. And that's
for something that it's so invasive, you have to respect the patient.
exactly. So this is my only point against in comas, which is, I think that maybe eventually in the future guided will be the gold standard, but doctors have to know freehand.
Yeah. Otherwise, they don't need to be there. They can get a robot to do it. No?
Yes.
That's what's making the difference. It's to have someone that can take decisions.
Yes.
Right. That's what doctor means. No, it's to be someone that is human and be able to take decisions on time.
Exactly.
So great.
That is my real point on I prefer to teach young guys to do very good freehand surgery instead of teaching young guys that will maybe, I would maybe pushing them into guided, they will never know freehand, and I will not be teaching a doctor to be a surgeon, I will be teaching a dentist to use the computer. That's not what we want to do,
Sure.
If they want to do guided in the future, props for you, go ahead, but I know that you know freehand.
Yeah.
That's what...
When everything goes wrong, you got the plan B, you got plan C, and everything. Your patient will get out satisfied from the surgery. Yeah.
Exactly.
Great. So another thing that I want to talk, and you already mentioned it, it's you have the idea of no-zygoma implants.
Yeah.
Please, tell us.
So, it's funny that you ask, because many people think that I am against zygomatic surgery, and I am not, In fact, I did a lot in the past. In fact, in the course, I show my own zygoma cases. But the thing is this. At some point, when I had contact with the new custom implants, I was kind of in a crossroads. And at some point, I had to make a decision like, what am I going to do to the very extreme cases, the cases that I cannot solve with standard implants? Do I go into the zygomatic journey, or do I go into this new one that made sense to me? And this is more philosophy than anything else, but I had to make a decision, and my decision was this. I may not have long-term follow-ups about the new patient-specific implants, but do I need them? Or does the concept itself makes enough sense for me to believe in this type of rehabilitation that could avoid the initial necessary destruction for placing zygomatic implants, especially the quad zygoma? Because I don't really mind the hybrid zygoma or even a single zygoma if a palatal approach doesn't go as I planned, for example, as a rescue. But especially on the quad zygoma cases,
also with a pterygoid implant.
Also with a pterygoid to eliminate the cantilever, right?
Yeah.
But
and to reduce the bending.
To reduce the bending, the micro movements and all that. And but especially on the quad zygo cases, that are cases that they have a very high
leverage of the
yeah, and plus they have cantilever always, and
big
almost
anterior,
posterior cantilever, and they are so atrophic in height that the zygoma will be almost horizontal, and the more horizontal is the zygoma, the more bending and the more movement it has. Plus that with the necessary destruction to place the quad, the slot on the sinus and all that, I had to make a decision. I go this way or I go the other way. And I decided to read a lot about the old subs, the Linko books, study the mechanics. Then we talk a lot about this in the beginning as well. And I saw how you design, how you plan, the finite element
and
analysis.
How we evolve with your help. Of course. I didn't tell, but Bernardo, it's a clinical advisor of Cornisi, and he gives us a lot of feedback and help us to always improve the implant.
For instance, when you started to segment the implant, that was a holy grail for us, because that was, I must tell you, man, it was so complicated to place the first one big structure. But now segmented, I mean, it's. I usually say this, and people don't get it at the beginning, but when they think about it, they will get it. Which is, this is perhaps the least invasive solution for a full arch case.
It is.
It is perhaps. Can you think about this? It's less invasive to do a custom implant than to do an Allen-4, right? Because I mean, you are working around the bone. You are not making holes in the bone and removing bone to place screws. Yeah. So
it's a 50 cent size, you know.
Yes. Yeah.
In reality, I have a picture. It's a 50 cent size, the implant. Yeah. Most of the people look at the pictures and they say, "Whoa, what a big frame!" It's not that big, no.
Mm-hmm.
Well, if we measure the size of a zygoma implant, 50, 55, or whatever, it's also a big thing, you know. But that's not the size. You
need to put spreaders over the zygoma, no? Which is, in my opinion, much more invasive also to do that.
I never, to be honest, and I've been telling this for years, I don't think that the size of the flap has anything to do with the invasiveness of the procedure. You know what I mean? I think that what is invasiveness? In the philosophical term, what is to be invasive in surgery? I think that to be invasive is to destroy bone or to change the bone architecture. That is what means invasive to me. Open a big flap, a smaller flap, for the patient doesn't make that much difference.
What it needs is to be an enough flap.
Enough flap. And, bigger, smaller, that doesn't really make the difference. What makes the difference is how much bone you need to destroy. That's what makes even to solve the case, to re-enter the case in a few years. That's what matters the most to me, is if this goes south, do I still have bone left for a plan B, for a plan C later on? Yeah. And I felt that with the quads, and I did a bunch of them, I was always wondering to myself, if this fails, especially on the younger patients, the 40s, 50s, I have nothing left.
Yeah. Oh, I see another problem on all my zygoma fail, mainly the quads. It's the time they stay with bending, the destruction they made, it's huge. It's huge. And sometimes we even lose the anterior nasal spine. It's really used because I think, my opinion, sorry, but we talk a lot about this. We talk a lot about this. In reality, we talk already. Even before we start this, we have talked a little bit about this. It's the question is if you have something that has micro movements inside bone, it will generate bone resorption, and that's much more like an ancient subperiosteal than the new patient specific, because the idea it's something that stays, that doesn't have any micro movements.
That's I think that is the biggest difference, right, between the old subs and the new patient specific implants. Is besides the whole fixation areas and points and all that, is that one is fixed and the other one was not. And the fact that it was not fixed, I mean, the gravity, first of all, will make sure that the implant will move, right? The gravity itself. And then the biting every day, I mean, they were doomed to fail. The upper ones, especially the upper ones. But now, I mean, we are talking about a fixed solution. It has nothing to do, because look, how many years are we doing the L4-1 surgery? 100 years. Right? 100 years. We are using the microplates in the same place that we are using now.
The buttress, buttress piriform.
And I never saw anyone complaining now about the fixation plates on the L4 surgery, right? Because
everywhere in the world they make about 1,000 or something.
At this moment, someone is placing
this type of plate
for 100 years. So we know that the principle is being used for 100 years every day, and suddenly there is a problem with these new patient-specific image. It doesn't even make sense to compare the old, the success rate with the old ones with the success rate with the new ones. It doesn't even. We cannot compare one thing to the other. It's apples to oranges.
It's so. Great. I can't resist to ask you.
Oh my God.
One thing. They always say that behind a great man there is a great woman. In this case, it's the other way. Behind a great woman there is a great man. But can you tell us a little bit about the logistic of about this? This must be hell.
It's crazy. In the first courses that we did, it was a big knowledge to manage everything and to not missing nothing. But I think we are doing a great job. But for me, the most demanding course to plan everything, it's the boot camp, because we have to deal with patients. Sometimes the patient cannot come. Planning. We have hours planning everything before the boot camp.
Another country, taking all the things that
we have to have a team there to work with us. Sometimes the difference of timing,
it must be crazy.
It's difficult sometimes to manage everything.
And the volume of cases, which is completely nuts. Can you imagine doing 50 arches in 6 days? 50 arches with 2 custom implants. Plus 2 custom implants.
Wow, it must be the days before you don't sleep with fear of forgetting something. No? I imagine that. I
have my checklist, but for me the most.
You are always thinking, instead of sleeping, you're always passing the checklist.
Before coming, I check again and I check again and I check again. For the master course, we are on 21st edition, so we have everything managed, and I don't need to check the checklist because.
And we also have a team in Brazil that helps.
But Brazil, it's the most challenge for sure, because we want difficult cases. We have to see. For instance, for the special ops that we are going to do in April, I have already seen 100 panoramics X-rays. So it's crazy to select the patients. And sometimes
it's good she does this part, I never know the cases. I know the cases at the same time as the students.
And Bernardo arrives
It's exactly.
So
upper, lower, or both.
So but it's really delightful at the end, because it's really nice.
In the end,
besides that,
people around the world.
It's really amazing.
should be great.
And I think we are doing a great job. So.
Yeah.
And you said something interesting, because the people we meet, can you imagine, Rui, we have received people from more than 30 countries.
I know.
More than 30 countries.
Yeah.
We have our private WhatsApp group that is going, how many people? 250? More or less. 250 full arch surgeons in one group every day, posting new cases, questions and all that.
It's really active.
So it's amazing to meet, people from so much different backgrounds, all together with one purpose, believing in graftless, immediate, full arch solutions, and just everyone trying to deliver the best to their patients.
Yeah.
Some of guys do the rehabilitation the digital way, some do the analog way, but you see it's in the end everybody wants the same, to run away from sinus lift, to run away from zygomatic implants, and to run away from guides.
Yeah,
this is what we see with everyone.
Yeah.
And actually half of our participants are people from the guided background.
Mm-hmm.
Can you imagine? 50% they came here because they
felt the need.
They felt the need for that, right?
Yeah.
So I think this also tells us that the academic teaching that I know that nowadays tries to push doctors into guided as soon as possible, it should be the opposite. It should push them first into freehand and only after into guides, right?
Sure.
But nowadays, unfortunately,
it's
commercial.
It's more easier to sell something that you don't have to sing.
Yeah.
You just have to use the guide.
Yeah.
I know.
And now with the AI, I'm pretty sure that it will be a matter of months, maybe 1 year or a little more.
The implants will be already placed on the exact places.
Yeah.
You just have to check it.
You just upload the CT scan. The AI does everything for you.
Yeah.
You just click on print, and it will print you the guide for the reduction, the guide for the implants, and you don't have to think where to place the implants anymore.
And that's the wrong way of using AI.
Yeah.
In reality, it's a great tool, but that's the wrong way to use it.
Yeah.
So, to finalize, I just want. I know you just said that you are going to, for future, this master course is going to move to Lisbon because you have lots of people from the United States and
Australia,
Asia. I know that you are about also to do a course in Australia.
It's true. I cannot tell yet the details.
Sorry, I do not tell this. But it's always good to know that Full Arch Club is growing.
Yes,
and with new projects, and it's always great. So at least 2 new things. One half thing, it's not Australian, it's oceanic. It's from it's not. We cannot tell. But great. So this course will move to Lisbon.
Yep.
For you, it's easier because you live near.
Yes.
Really. And you go often to Lisbon, right?
I would say that I have to go for one reason or other, like every month or so, to Lisbon.
But to Oporto,
it's 4 hours driving, and
it's more difficult.
I like to run also. If I spend 4 hours each way, it's one less run that day.
It's really
so
guys, it was really, really, really great. This
Thank you.
I love you. First, I love you really.
We love you too.
You are really great. I'm so proud of you because I knew Bernardo. We had the meeting. So there was first you called me.
Yes, you know how we met? Someone told me that there was a crazy dude. There was a crazy dude in Porto picking up the concept of linkosubs, and I was like, what? I have to know this guy. Then I called you, I think.
Yeah, and then we met in Lisbon.
Yes, we spoke about this in Lisbon.
And from there.
And you told me, look, I'm going to do a custom implant surgery next day in Porto. And I said, text me the address. That day I came here, remember? I came here, and I was actually having a coffee, and because I was waiting for him to use the anesthesia and all that. When I actually entered the surgery, after the coffee, he was already starting to suture. One of the fastest surgeries I ever saw.
No way.
Yeah. And it was the time of an espresso. And
No,
it was true.
I like very much of logistics,
You're not the only one.
Yeah, I think the time that we get fast, it's the time that we use for thinking logistics.
Yes.
You know?
Yeah.
I have people that stops too much during a surgery.
Yeah.
That's terrible.
We use the same philosophy, you know.
Yeah.
It's, I mean, if I have to wait like 5 seconds for an instrument, I start to become green like the Hulk, you know. It's like,
it's gamma rays.
No.
It's gamma rays.
I think that the ideal surgery should be between 30 minutes, 45 minutes. This is the ideal time. And it's enough for most of the cases.
Start to put again anesthesia, it's going to be difficult, and patients stop cooperate, and everything starts getting bad.
By the way, you know that now with your segmented implants, with the compact ones, I find my surgeries way faster than it was before.
It's true.
Yeah, I can
because you know,
you don't need so many.
I don't need tryouts.
I don't need.
That's
It's true.
which allow us to run away. When I say work fast, I don't mean to rush. Is to run away from general anesthesia. That's what I want in a fast surgery. So having the implant now segmented, it's a great thing.
It's really fast. Guys, it was really great. It was a pleasure for me to have the most famous guys around the world.
I have one question. Bernardo has one question.
Yeah, sure.
Nathan from Tijuana, Mexico, he asked, in all the videos I have seen that the torque is very high. However, the implant companies recommend less than 35 newtons. Because we can produce necrosis, how can we avoid with high torques?
Yeah, that's a great question, and you know, it was years ago that the myth of the high torque and bone necrosis was true. It's not true anymore, and in fact, if you go to the most recent studies, the systematic reviews, you see that they don't even find a correlation between high torques and bone necrosis, or even marginal bone loss, or loss of integration. That just doesn't exist nowadays. And one thing that you have seen on the video, that's why you asked the question, if that was true, I would be losing all my implants, right? I think you agree with me. If this was true, I wouldn't have a single implant in place by now. And
it's the opposite. You have a greater success with high torques than less.
Exactly. It's the opposite.
Yeah.
It's very common for us to place implants with 80, 90, 100 newtons, and they won't fail because of that, but they will fail because of lower torques.
Yeah.
Mm-hmm.
Also, just a note, Kyriakis is on the chat and he said, full Arch Club, change our way of thinking, change our way of operating.
Oh, nice.
He was. Cheers for you. He was here in the last edition. Yes.
Okay, guys, great, and
thank you.
for the people that follow us. Next month we are going to change a little bit the subject. We are going for orthognatics, custom-made, minimal invasive orthognatics, and ICMF cases of bone facial reconstruction. I hope you like it, guys. Thank you.
Thank you again.
Okay.